This morning at Neurosurgery Grand Rounds, and also that he is joining a Swedish medical group, and he'll be starting his practice here in Seattle in August. Dr. Gupta did his otolaryngology at NYU and then a 2-year fellowship at UT Southwestern. And following that was an attending at Walter Reed at National Military Center. And subsequently, since 2017, has been practicing at OHSU in Portland. We are very pleased that we're able to steal him north here to Seattle. And as I said, he'll be starting in August. He will be doing skull-based surgery, acoustic neuromas, cochlear implants, and endoscopic surgery. And we are just delighted that he is joining us. One of the things that I noticed when we were recruiting him was that he was awarded Teacher of the Year at OHSU. And for a young faculty, I think that speaks very highly of the kind of individual that he is and the rapport that he had with his residents. And I think the residents always know what's going on, and that's a very coveted award. And we are delighted to have Dr. Gupta both here and joining us at Swedish starting in August. So welcome, Sachin, and you can share your screen and take it away.
Thank you very much for having me. I'm excited to come up there and join the group, and doubly excited to be able to share some of the work that I've been doing for the last several years in Portland, namely on this topic of endoscopic ear surgery. And given today's audience is primarily neurosurgical, I'm going to try to really go through things kind of systematically. So the first thing I'm going to talk about is some of the principles of why I approach middle ear pathologies with an endoscope through the ear canal. And this picture that we can see is actually an endoscopic view in which we can see a pretty broad exposure of the middle ear that includes the incus, the stapes, and the cochlea. I'll go through a little bit about endoscopic middle ear anatomy and why I prefer to use the endoscope to access some difficult to reach areas of the middle ear. I'll then spend pretty much majority of the talk showing some videos and of some surgeries that I typically do in otology in the middle ear, and showing how the endoscope, how I utilize it, and what my ways of approaching that are. So to make things clear, the first thing we're going to be talking about today really is the middle ear. So the middle ear is the space that's separated from the external auditory canal by the tympanic membrane. And what we are going to be talking about is pathology affecting the middle ear, whether it be the tympanic membrane, the ossicles that control hearing, or any other disorders that also can then spread to the mastoid as well, which is posterior to the middle ear. So traditionally, middle ear surgery is done using a microscope. And this is a pretty typical setup. This is actually one of my residents at OHSU. The head of the bed is turned 180 degrees from the anesthesia team. The surgeon is operating through a microscope, and then the observer is looking through the side lens. And the scrub tech is across the screen from the surgeon, across the patient. To access the middle ear, there are really two ways when you use a microscope. One way is work through the ear canal itself, using usually a 7 or 8 millimeter speculum with two hands, working through a narrow ear canal with speculum. The other way is to make an incision behind the ear, what's called a postauricular incision, to really access the ear canal broadly and to give exposure of the mastoid cortex. And so this is a nice anatomical picture that really shows how you can access the eardrum as well as the mastoid through this postauricular incision. And because of the broad exposure that people get, this is really considered the workhorse approach for addressing the middle ear and mastoid. Endoscopic ear surgery, on the other hand, it involves using a high definition screen along with an endoscope in the ear canal, using the left hand, assuming the surgeon is right-handed, and then using the right hand to work above the endoscope through the ear canal to do surgery in the middle ear. And so everybody is looking at the same screen, but again, it is one-handed. The benefits of using an endoscope are that it enables you to basically bypass the narrowest segment of the ear canal, providing a wide angle of view around corners that the ear canal will sometimes obscure. The left side of the screen shows the access that's obtained with the microscope, namely that you can either work through the ear canal, limited by the ear canal, or you can make an incision as we show to give wide access. So some of the advantages in particular for using an endoscope are that you can obtain wide exposure of the anterior sulcus, namely this part of the eardrum, which is anterior towards the eustachian tube, is more readily seen with an endoscope. You can obtain access to the anterior epitympanum. This is a space above the middle ear space going towards the mastoid. And this area in particular, the anterior epitympanum, is generally considered a problematic space to access through the ear canal. And then lastly, posteriorly, you can access the retrotympanum. And that's really posteriorly here near the stapes, and then posteriorly going towards the mastoid. One of the other benefits of endoscopic ear surgery that I've come to realize over the years is that it does improve collaboration with the OR staff as well. Working off one big screen, everybody can see what each other is doing. When they pass me instruments or pass me packing materials, for example, they can see what I'm using and understand how to help me do the task I'm trying to achieve. Over time, my operative time has become much shorter using an endoscope. Prior to using an endoscope, I did tympanoplasty. Typical time would be maybe an hour to an hour and 15 minutes. Now, when I do a tympanoplasty, it could take me 40 minutes to do it. So pretty significant drop in operative time. And I think a large part of that is just because I have a good flow in terms of achieving hemostasis. And of course, I don't have to open and close an incision. The patients have decreased pain and faster healing after this approach, mainly because you're not making an incision behind the ear. It's rare that I have patients who use a lot of narcotics. Usually by the time I see them about 2 or 3 weeks after surgery, the whole eardrum, all the work I've done is fully healed. And so that's really nice in the sense that my postoperative care is pretty streamlined. And then lastly, patient counseling is a huge benefit of this. I have amassed a large video library of these cases. I like to show patients their pathology. Some of them will have me record their surgery so they can have it for their own records. But it really helps patients understand what I'm exactly doing in their middle ear, which can, to many patients, be a real mystery. And of course, doing this sort of surgery, which entails risks of hearing loss, dizziness, tinnitus, change in taste, all of these things can create a lot of anxiety on the patient's side. And so being able to show them what I'm doing is very helpful. So as with any new approach, there are some disadvantages. The main disadvantage is the learning curve. It's a single-handed technique, using one hand to hold the endoscope while using the other hand to operate. So there's some ergonomic considerations that come into play. Depth perception, always an issue using an endoscope. When I was at OHSU, there's some issues with, addressing pituitary lesions. Some neurosurgeons would actually prefer a transeptal approach with two hands using a microscope versus an endoscopic approach. And so I think there's a lot of sort of getting used to having to use an endoscope, moving it in and out to gain that depth perception. And then bleeding, because you're working in a narrow ear canal, bleeding is often an issue that holds people back from doing this initially. I have a certain way that I inject. I use 1 to 1,000 epinephrine cottonoids. And by doing that, I'm able to minimize the bleeding. And I'll show some videos that kind of illustrate sort of typical bleeding that you can expect. And then instrumentation. One of the disadvantages of this is you do need some special instrumentation to do this. In otolaryngology with sinus surgery, they don't always use 3-chip cameras and LED screens, but to do this surgery, you really do need a 3-chip camera. ideally a 4K screen or at least an HD LED screen. And there are certain endoscopic instruments you can use to help you get around these corners and angles to really do the surgery effectively. And with that being said, I mean, this is a slide showing the instruments that I typically use during every case. And so it's not a lot of instruments. I mean, there's about 6 micro picks here, a 0 and a 30-degree endoscope, cottonoids and gel foam soaked in 1/1000 epinephrine, and then alligators, cup forceps, micro scissors, and then suctions of varying sizes. So it's really not instrument heavy for me. And I think a lot of that's because I've just done so many cases now that I can really able to do this in a streamlined fashion. And I think the scrub techs appreciate that. So going back to anatomy now to kind of talk a little bit more about, what we're approaching. C on this picture here shows a typical approach when you access the middle ear and what you see. So when you lift up the eardrum, typically what you see is the malleus, which is anchored to the tympanic membrane, the incus, and the stapes here. And then you see the cochlea inferiorly with its round window membrane. Covering this epitympanic space, the space above the middle ear, is the scutum, which is Latin for shield, but it's a covering of bone that we then remove through the ear canal to then access the epitympanum as needed. So here we can see cadaveric shots of the anterior epitympanic space here. This is a space that's anterior to the malleus head, and here you can see it zoomed in. Working with a microscope, again, this is very difficult to access through the ear canal, but with an endoscope, I see this space pretty clearly. Posteriorly, we talked about improved access to the posterior epitympanic space and the retrotympanum. Here we see the incus and the stapes here, and then posterior to this is a space called the sinus tympani, or subpyramidal space. And this diagram is a little complicated, but it shows basically all the varying conformations of the space, can have varying sizes, varying depths, and this can be a really difficult area to access with a microscope. And by using 30-degree and often actually just using a 0-degree scope, I can see this area pretty clearly. And that has really helped me on cholesteatoma cases in particular. So in terms of trying to understand this, instead of just a subjective fashion like I have so far, Bennett from Vanderbilt, the group there actually looked at this and tried to quantify the actual visualization that you get with an endoscope versus a microscope. So they took CT scans from 6 normal patients and subsegmented the middle ear. And using 3D regional volumes of space, they looked at areas that could be reached by a microscope versus a 3mm endoscope. And so what they found was that when the ossicles were present, that an endoscope, a 0-degree, had 90% visibility of the eustachian tube anteriorly and 62 to 82% of the other areas, namely the posterior sinus tympani, as well as, again, anteriorly, the supratubular recess, which is very anterior. The microscope, on the other hand, had visibility ranging from 14 to 29%. Now, typically in these cases, if we're trying to access disease in these areas, we will actually remove the ossicles to try to improve visualization. And even with the ossicles removed, the visualization of these areas was 14 to 31% with the microscope, whereas the endoscope, it was 62 to 90%. So, I mean, this is not particularly surprising. We know the benefits of endoscopes in other parts of the body, but this is a nice study that really quantified this. So I'll move forward. We can do questions later on. But so in terms of surgeries and what I actually do with the endoscope, the first one, the most common one, is tympanoplasty. Tympanoplasty is basically an approach in which you're repairing the tympanic membrane when there's a perforation, a hole in the eardrum. As we discussed, you get some improved visualization anteriorly to fix these holes that are really difficult to reach, and the depth perception is a little different. So I'll play a video right now. So in this video, I was repairing a large, what we call subtotal, meaning that almost the entire eardrum is gone here. And typically I would have done this with the microscope with a post-auricular incision, but I did this with an endoscope. This is actually like my first year of doing endoscopic surgery. So first, we make some canal incisions in the ear canal in preparation for lifting the ear canal skin up with the eardrum, what's called the tympanomeatal flap. Here we're using a cottonoid that's soaked with 1 to 100,000 epinephrine to help lift up the eardrum. And I like to do this because it really helps sort of achieve hemostasis as we go. Here I'm palpating the malleus and incus to make sure they're all working. And here we've lifted the eardrum completely off the malleus. I put some gel foam packing, and now I'm placing my cartilage grafts to reconstruct the eardrum. Finally, I put some perichondrium on top of these cartilage grafts. And I should have stated, but I get the cartilage grafts from the tragus. So it's a pretty small incision the patient doesn't see, and with really quite minimal morbidity there. But by doing this, I can see actually, after we place this graft, you'll see I can basically see the entire hole, see where my graft sits against the remnant eardrum, and really confirm my repair looks good. And then here I'm laying down that skin flap that I started with, and we can see the reconstructed eardrum pretty nicely here. So by doing cases this way, I really found a benefit in terms of not having to use an incision, patients having lower anesthesia time, and of course, again, faster recovery. And my outcomes have been equivalent or better doing it this way. Here I'm using a suction just to inspect things, and then putting some gel foam to help secure the graft and help it stick. And then lastly, some Piercing ointment. So stapedectomy is another surgery I often do. This surgery is usually can be a point of anxiety for a lot of ear surgeons. People who do a lot of ear surgery tend to do a lot of these. It's one of the most rewarding surgeries we do, in the sense that we restore hearing pretty immediately for patients. In this disease called otosclerosis, patients will have disease in which there's bony fixation of the stapes footplate. So if we look at this diagram here, there's a small stapes bone that's about 2 millimeters, also called a stirrup, in which on the base of it, there's bony growth that stops it from moving. This classically presents with a middle ear related hearing loss or a conductive hearing loss. And the options generally include doing surgery, what's called a stapedectomy, or doing hearing aids. The surgery is traditionally performed using a microscope with two-handed technique through the ear canal using a speculum, as I showed earlier. The risks of surgery include about a 1% chance of severe hearing loss. So for years now, I've been doing this endoscopically because I really like the visualization of this area around the stapes. And so this is a nice video. This is a surgery I actually did a few months ago. Here again, I'm making some canal incisions, connecting up the incisions with a round knife here, elevating the flap. Use a cottonoid to help get hemostasis and help me get to the annulus where I'm lifting the tympanic membrane up now. As I lift the tympanic membrane here, I'm entering the middle ear, and there we see our incus and our stapes here, and our chorda tympani, which controls taste, to the front of the tongue. Using a scissor to cut the stapedius tendon. Here I'm using a CO2 laser to laser the posterior aspect of the stapes superstructure. I'm using a Rosen needle to break through and make sure I'm through that part of the stapes. Here I'm breaking the stapes superstructure off, we call down fracture. Removing that. And then here we can see the stapes footplate where I'm going to make an opening now to put the prosthesis into. I measured it, it's about 4 millimeters, that's a typical size. Putting some tragal perichondrium, lasering this area now to make an opening. using what's called a rasp to break open, make sure I have a nice opening into the foot plate. Laying and sliding the perichondrium over this opening now to help seal it. And then lastly, putting a prosthesis. I use a lippy bucket handle prosthesis made by Grace Medical. I'm very particular about the prosthesis I use because this is now a one-handed surgery. And so I found that this works the best in terms of placement. And I really like doing this perichondrium because I think it really minimizes dizziness and vertigo after surgery. And there you go. Now we have nice movement that we reconstructed. And then I drop down the flap again. There's our eardrum. So this surgery typically takes about 40 minutes or so to do. Then laying some gel foams here to help the flap just kind of stick and scar down. So one thing I've found is that the endoscope is particularly helpful in this area when I have an overhanging facial nerve. And so I've had a few of these cases now. This is a patient who had it. You can see a conductive hearing loss here. And actually has a little osteoma as well here in the ear canal, a little bony growth. Try to fast forward here. Here we're entering the middle ear. We're removing bone from the scutum, the ear canal, to help see our incus and our stapes bone. Separating the incus from the stapes, lasering it. And then as I lasered, I realized the facial nerve was very close here. So I removed the stapes. And if we look here, we'll see the facial nerve is actually covering half of the area I usually have to work with. So the facial nerve was largely in the way here and actually uncovered with bone. It was dehiscent. So with this case, I decided not to use the laser just because of the risk of heating the facial nerve. So I used the pick. I used then what's called a Buckingham drill to widen the hole into the inner ear. There's the hole, which you can see. I'm going to try to widen it a little further to aid with prosthesis placement. You can see the fluid coming out there now from the inner ear. There's the opening. Laid some perichondrium. And then I use my pick to try to make sure that I can get a sense for where that opening is under the perichondrium. And then we'll put our prosthesis over that. So in this case, what I really gained the benefit was being able to see that facial nerve pretty clearly and really being see the area that I could reconstruct. I think sometimes it can be really hard to see as the microscope, and I just prefer. I'd rather operate one-handed and see more of what I'm doing for these cases. But it was definitely a learning curve, but I've become very comfortable doing it this way. So moving on to more chronic ear disease, we'll talk about cholesteatoma here. Cholesteatoma is a benign skin growth of the middle ear, which can be very challenging to surgically treat. The issue is that people can develop these skin growths, and there are many reasons why people think this happens. The most widely accepted theory is actually what's seen at the top of the slide, which is that the eustachian tube doesn't work well, it doesn't open normally, and then you get a middle ear vacuum, which draws in the tympanic membrane over many years. As the tympanic membrane then draws inward, you then develop skin or epithelium that collects in this pocket, and eventually it forms a biologically unique skin growth that then erodes bone around it. So the most common symptoms that patients have with these cholesteatomas are hearing loss as the ossicles are eroded. They could also develop otorrhea or drainage from the ear as they get infection of the skin growth. In 2 to 3% of cases, it can advance into the mastoid and actually erode the inner ear, what's called the labyrinthine fistula, causing dizziness. And then in less than 1% of cases, it can go superiorly intracranially. And so, not too long ago, there were people who would actually die from this because it would go intracranially. Fortunately, with the operating microscope and our imaging techniques, that's extremely rare nowadays. But these show that the varying theories for why cholesteatomas form. Another theory is squamous metaplasia, which is that inflammation in the middle ear mucosa itself leads to transformation of the mucosa to epithelium. This has been observed in animal models. However, it's really tough to reconcile clinically because we usually see some sort of retraction or collapse of the tympanic membrane. Squamous immigration is another hypothesis, which is that if there's a perforation, skin will grow in through the perforation. That's also called a secondary acquired cholesteatoma, which we do see in practice. They're less common and they can be very challenging cases, but they do occur. And then lastly, squamous basal hyperplasia. This is a theory in which basal keratinocytes basically penetrate, the basement membrane, extending into the subepithelial space. And so this is, again, mostly observed in animal models, has not really been shown in humans just yet. But nevertheless, the treatment for any sort of cholesteatoma is surgery. There is really no good medical treatment for this. So the goals of surgery are to eradicate disease, doing a tympanoplasty in which you remove the pocket and graft it, mastoidectomy as needed to address disease, ossicular reconstruction, improving the hearing if the ossicles are eroded, which can either be done at the first surgery or later, usually on average 9 to 12 months, and then surveillance. Surveillance for the disease is very important. I typically see my patients once a year for an ear exam with an audiogram. And then if I'm confident the disease is not there, I'll get an MRI with non-echoplanar diffusion weighted imaging at about 2 years after surgery, and then at about 5 years. The recurrence rate of this disease in the literature historically has been 20%. So fairly high, which is why, again, oftentimes we do end up doing what's called a second look surgery, in which we go back in 9 to 12 months to make sure there's no regrowth of disease. And so here we actually see a diffusion weighted MRI, which shows a diffusion weighted positivity for cholesteatoma here, cholesteatoma recurrence. So with an endoscope, my approach is I basically go through the middle ear as we showed endoscopically. I remove that scutum, that superior part of the ear canal as needed to visualize the disease. And then I dissect the disease out in the middle ear. And then if the disease is going posteriorly into the mastoid, I'll then use a microscope and drill the mastoid to remove the rest of the disease. So I'll go through some different conformations of this disease. It can present in many different anatomical ways. The first one is epitympanic cholesteatoma or lateral epitympanic. These are cholesteatomas that come lateral to the ossicles, so on top of this ossicular chain. And these can typically be removed by removing the scutum and then peeling them off the ossicles. So here's a video in which a patient actually had a recurrent epitympanic retraction here after a previous surgery for cholesteatoma. And the previous surgeon did not use cartilage here, so it looks like it just collapsed in. Here I'm removing the previous prosthesis off the stapes. I'm curetting using a bony curette to remove the bone here to get into this area to access the pocket that's occurred. Here I'm going anteriorly, really to the anterior epitympanic space, start to dissect disease. Here I'm going posteriorly and I'm dissecting disease off the malleus head right here. I'm using what's called a nipper, malleus nipper, to cut the malleus head. Now, because the disease is draped on the malleus, I decided to try to deliver it with the malleus. And so I'm doing that gently, some gentle pulls here. A lot of this is just getting experience in terms of how much force I can put and what is appropriate for the disease, but this case went pretty well. Here we see the mucosa that's lining the pocket there. And then here I'm finishing my removal, and there's a little bit disease up here superiorly that I removed. Here, removing the remnant of the incus that was used to be there off the stapes, which will help the prosthesis sit better than it used to. Using tracheal cartilage to reconstruct the scutum defect here so that they don't have recurrent retraction. So I think this is really important to use some cartilage. Putting a partial prosthesis made of titanium on the stapes for hearing. I'm going to put some gel foam here to help secure that. And lastly, putting another piece of cartilage over that to help conduction and help prevent the prosthesis from coming out through the eardrum. And here we can see it's laying nicely on there. And then I use some perichondrium, some soft tissue graft to help the eardrum conform to the grafts and help it heal better. So at the end, this is what we've achieved. We have our remnant eardrum, we have our grafts, and the patient did very well. So here's another video. This is another cholesteatoma. This one was an actual skin growth here, not a retraction pocket. And so you can see the white mass behind the eardrum here. On a CT scan, we could see that there was erosion of the incus here, the coronal slice. So again, making canal incisions. As we lift up the eardrum, we can see the actual skin growth right here, this white pearly structure. Starting to deliver it from inferior to superior, we see our cochlea there. And as we further progress the section superiorly, we find our stapes right there. And the incus was eroded. There's no incus connected to it. So because that was the case, I then removed the rest of the incus here. We can see facial nerve here right above the stapes. Because the ossicles were already disconnected, I then removed the malleus head in order to access that anterior epitympanic space we discussed. And then here using an angle endoscope, I'm looking and I can see everything looks really clear of disease. And then looking anteriorly in the anterior epitympanic space, I don't see anything up there either. Now I'm using cartilage to reconstruct the bony defect from the disease here. Putting a prosthesis again on the stapes to reconstruct hearing. And then again, laying cartilage on top of it. And then perichondrial graft. There we are, we're finished. So this patient did very well, has not had recurrence for about 3 years at least, and the hearing is normal at this time. So we've talked a little bit about anterior disease now. We can look at posterior disease or retrotympanic disease. So this posterior area, again, is very difficult to access traditionally. So this was a patient who had a recurrence of cholesteatoma after a previous surgery. You can see this white mass here. And then here you can see it actually going into the facial recess here posteriorly, which is typically done by going through the mastoid. So again, lifting up the eardrum. We see this bundle of scar here covering the previous cartilage graft the other surgeon had placed. Lifting up that cartilage graft, we can see the old prosthesis. Going to remove that because it wasn't quite in place. Curetting, removing some bone to access the disease, the area where I think the disease is. And then we're going to start delivering the disease out now. Now the key is here to really make sure I'm on outside the capsule and not intracapsular. And so I'm always looking for this mucosal plane, this clear mucosa around the disease. And that helps guide me as I do this. Knowing that if this disease were to burst, if there was to be a spillage or some problem, that I would just go into a mastoid. But this came out really cleanly. There we go. And so this patient I surveilled with MRI. At 3 years, she has not had any sort of recurrence. There we see her stapes. That's what I was just looking at. Put our prosthesis in, and then lay a nice big piece of cartilage. Making sure everything looks nicely opposed, everything looks clean and in place. There you go. So, and lastly, cholesteatomas can get quite messy, and they can definitely involve the mastoid. So in disease where the disease is going medial to these ossicles and going posteriorly back into the mastoid, I'll again remove the ossicles, but then drill a mastoid as well to address that disease. And so what I initially struggled with was, how do we decide when I have to drill a mastoid and when I don't have to? Because sometimes disease up here can be really difficult to access with an endoscope. And so we actually looked at this at OHSU. We reviewed about 106 consecutive temporal bone CTs over a 4-month period. These patients had not undergone surgery. About 174 ears reviewed. And we looked at confirmations of the zygomatic root and tegmen tympani. And so what we found was that we divide them into grades, and basically about 33% of patients had this grade where there was really a common wall between the tegmen, the skull base, and the ear canal. About like 65% had grade 2, where there was some distance between the ear canal and the temporal lobe. And then lastly, there's grade 3, where the zygomatic root is very highly developed, very aerated. And you can see the space now between the malleus head and this superior aspect, this tegmen tympani, is quite large. And so this really helped me kind of understand. I started realizing that the cases in which I was spending the longest operative time were these grade 3s. And what I started to realize was that if it was a grade 3, I pretty much would plan on removing disease from this area and then drilling a mastoid to get to all this superior disease above this malleus head. It was just much easier to do it that way. Whereas these grade 1s were super helpful to recognize, because then I came to realize that there was no point in even trying to drill a mastoid in these cases. And in fact, in the past, I might have done a canal wall down, meaning I might have actually removed the ear canal and done a bigger operation. Now, using this preoperative planning, I could then go in and remove this disease confidently, knowing I didn't have to do that operation. So it really enabled me in terms of my problem solving and deciding when to do a mastoid. These grade 2s, again, I would look at the distance here. This sort of case in particular, I would probably just do this endoscopically, because I know if I remove this bone right here, I can just get to this area above the malleus head after removing it pretty easily. But again, as you progress to this greater amount of zygomatic root development, I even tell patients preoperatively there's a good chance I'm going to have to make an incision and drill a mastoid. So this is actually another cholesteatoma, and when I'm suctioning, you can actually see there's a retraction pocket and epithelium that's going deep into this pocket here. I lifted up the eardrum as normal. And as you can see on these cases, there's a little bit more bleeding just because of all the chronic inflammation from the disease. try to speed this up. So here, as I'm elevating the drum, you can see this skin growth right here, this white mass right there. I have first identify the stapes. I then start to peel up this disease and see where it's going. My next step is to start anterior in that anterior tympanic space, because that's always the best area to reach with an endoscope. I find the plane between it and the bone there, and I just start peeling it from anterior to posterior. I can see the bone there that I'm peeling it off of. And then after I started doing this, when I look at an angle scope, I can see there's more debris posteriorly going towards the mastoid here, which aligned with my preoperative CT scan as well. So at this point, I then decided to drill a mastoid. Here, most of the mastoid has already been drilled. You have the ear canal in front of you, and I'm using a cutting burr. And then by following the tegment and thinning the ear canal, I start to see the cholesteatoma there in the mastoid. So whereas in the past, I might have done this fairly routinely for a lot of cholesteatomas, I probably do this for a very small minority of them now. And then here I'm packing some gel foam into the mastoid after I've already drilled it. So some of the burning questions are, do these endoscopic approaches have the same sort of hearing outcomes? And so there's a study from UT Southwestern where I did my fellowship, actually, where they did a retrospective study of 62 patients who had a sacral chain reconstruction, either with an endoscope or a microscope, and they found no significant difference. And this has been my experience as well, where I haven't really noticed really a significant improvement or significant decrement with doing endoscopic approaches. The other big question is, with cholesteatomas in particular, is does using an endoscope actually decrease rate of recurrence? And so intuitively, if you could see what you're doing a little better and clear the disease, you would think you would have lower recurrence. There are some studies showing that the recurrence rate is similar to that with the microscope. There was a study that was recently published. It was a trilogic thesis from Vanderbilt, where they actually found the second looks reduced the cholesteatoma recurrence just whenever an endoscope was used, from 16% to around 2.7%. So that's a significant drop. And so, my opinion on this is that using an endoscope, I feel like my cholesteatoma recurrence rates are quite low, but certainly if it's in the mastoid or in the sinus tympani posteriorly or really anterior, I may do a second look in 9 months anyways. Fortunately, MRIs have also helped us as they become more and more accurate for detecting disease. The unfortunate thing about an MRI is I really can't see recurrence for at least 2 years after surgery. And that's because the cartilage grafts themselves lose blood supply over the first year. It can show as being diffusion restricting, so it can give you a false positive result. And so MRIs are helpful, but again, only at least 2 years afterwards. But in my experience, again, I do think the endoscopic approaches, just based on my comfort level and experience, have decreased my rate of recurrence. This is another study looking at pediatric ears in which they used endoscopes either for inspection or dissection of disease, and they found the recurrence rate to be pretty similar in pediatric ears. What I will say about pediatric cholesteatoma is these are generally more aggressive disease processes, and they do have much higher recurrence rates across the board. So that's about all I have today. There's the International Working Group on Endoscopic Ear Surgery, which I'm a part of. They have a lot of nice videos and information about this. On YouTube, I actually have a website, portlandear.com, and a YouTube channel with videos. Brandon Isaacson, who was my mentor at UT Southwestern, who really got me started with this, has a really nice YouTube channel as well with endoscopic surgery. And here's my contact information. I'm happy to take any questions people may have.
Terrific. Thanks so much, Sachin. That was great. It's pretty fun to wander into an unfamiliar world and beautiful images that you show and really interesting. I can see the appeal of the endoscope, and I can also see why your residents thought you were such a great teacher. So that was really fun. What's the general adoption rate for endoscopic techniques in this area out in the world? I have no concept of otolaryngologists in terms of what the adoption rate is for this.
Yeah, so actually internationally, it was adopted very quickly, much earlier than the United States. Like in the late 90s, people were publishing papers on this and using this in South America and the Middle East and in Europe. In the United States, when I started doing it was in 2015, my second year of fellowship, and Brandon Isaacson had just started doing it at that time. And he's now considered almost like an authority on this. Like he travels all the time to give lectures on it. In terms of regionally, in the West Coast, there's not a lot of surgeons who probably do it primarily this way, sort of totally endoscopic, like the way that I was trained to do. I think in residency, I will say is that it's become much more popular. Pretty much, I would say every resident I've had who I've taught at OHSU who does ear surgery in general practice does it with an endoscope. And so it's been nice, but they've really found it super approachable. They do a lot of sinus surgery in residency, and this directly correlates with that skill set. And the biggest thing that they tell me was that they could just see what they're doing. And, the teaching is greatly facilitated too, because I'm not looking through a side, lens of a microscope where I have two-dimensional vision. So it's much easier for us to teach. And so I have junior residents doing tympanoplasties. I'd have senior residents doing cholesteatomas, and that was pretty challenging to do before the endoscope. So I think the adoption is increasing. I think it's going to be many years before people really adopt it routinely. But yeah, I love it. So,
and what do you find? I'm presuming that when you went to Portland, you had to build your team. What's the learning curve like for the OR staff? I again assume that everybody seeing it, as you mentioned, helps a lot. Everybody sort of being on the same page.
The OR staff actually adopted it really quickly. I think in places where you have scrub techs doing ear surgery who may not do that exclusively, and they have to come in and deal with all these micro instruments and all this instrumentation, it's actually far easier for them, the people starting out, because they can again see what I'm doing. And so actually the people in the OR have been the most positive about it and most excited about doing it because they just feel less intimidated by doing those cases with me. In terms of instrumentation, I think the main challenge has been that you have to have like a 3-chip camera. And unfortunately, some of the cameras that are used by the sinus surgeons aren't always 3-chip, and because they just don't need it for the space they're working in. And so fortunately, big academic center, they had all the equipment I needed. But at Walter Reed, for example, we didn't have that. So that was a bit of a problem.
Yeah, the image quality was just spectacular. That was really nice. Yeah. Any questions from the panelists?
Morning, Sachin. It's Zach Litvak. And given that I'm still recovering from COVID and probably appear horrific, I'm not coming on camera. But thanks for the talk this morning. Really exciting stuff. First of all, I hope that you've already reserved seattleear.com as a domain, because portlandear.com is so yesterday. One of the things that struck me during your talk, and you sort of alluded to it, is it looks like ear surgery is going through the same evolution that endoscopic pituitary surgery did. Yeah. And right now you're sort of in the phase of it's more than a novelty. It's not entirely widely adopted, but a lot of the procedures are the same exact operation with almost the same instrumentation, but different visualization. And so I'm wondering where you think some of the development opportunities are in terms of new instrumentation and or actually changing how the surgery is done in a way that you really push it forward in terms of outcomes and recovery, such that the naysayers are won over and say, okay, this really is a better way of doing it than the equivalent in pituitary, which would have been, instead of drilling a mastoid, doing a sublabial incision and exposing the entire piriform aperture?
Yeah, that's a great question. I think in terms of development, there's still a lot of development that has to be done for this to really optimize the surgery. The first thing is, you saw in some of the videos, I was using a bone curette to remove the bone there off the ear canal. That can be very tedious, and the curettes have to be sharpened, and it's really not a super efficient way to do it. And so, Stryker has they have the sonopet, and they have bone attachments for that can be used. Those work well as well. They irrigate, but it's a little messy. Another company, they've been working on a drill that actually irrigates and suctions as you work through the ear canal. And I think that's something that could really help us in the future in terms of removing bone efficiently and cleanly. Other things, include, I was trying to develop a speculum some time back that would actually expand the outer portion of the ear canal, the cartilaginous ear canal, so you could work through it. Because some of these people have very narrow ear canals, or their soft tissue is collapsed, and so the endoscope fogs often. So that can be frustrating for people. In terms of the actual micro instruments we use, there's a lot of sets now. I think we have an abundance of instruments, to use. I think a lot of really optimizing this is really the problem solving and understanding when to use the endoscope, when to drill. And that's what I'm trying to do to make my surgery a little bit more efficient and effective. But I hope that answers your question somewhat.
Yeah, great. Any other questions from the panelists? All right. Really appreciate it again, Sachin. Nice seeing you. Look forward to you being up here in Seattle next month, and let us know if we can do anything to smooth your pathway here. So thanks again so much for the talk this morning, and best of luck with your move.
Thanks a lot. Appreciate it.
Okay. Bye-bye now.